Hi, my name is Tripti Nagar. I'm currently a third year internal medicine resident at APRH. Today, I'll be discussing our QI initiative addressing healthcare disparities for colorectal carcinoma screening. Healthcare disparities for cancer screening are defined as differences in the incidence, prevalence, mortality, and cancer burden among specific populations in the U.S. Differences in the quality of health and healthcare are most prominently seen in and across racial, ethnic, and socioeconomic groups, to name a few. Understanding population specific differences can be imperative in improving our patient health outcomes and access to treatment. Colorectal cancer is the third most common cancer and the second leading cause of cancer deaths for both men and women. Screening guidelines have recently changed and is now advised for average risk persons between 45 and 75 years of age. Despite clear guidelines, we've noticed many patients delay or avoid screening in our resident clinic. Our QI team wanted to explore the disparities that may exist in this patient population and propose solutions to these barriers. The aim of this current PDSA cycle is to identify disparities in our resident clinic regarding colorectal carcinoma screening to increase the rate of screening in this population by 20% in 1 year. This year, our PDSA cycle primarily focused on identifying patients with a language barrier or limited English proficiency who had not obtained colorectal cancer screening. Before discussing our methods, I wanted to review our past PDSA cycles that demonstrated a significant improvement in achieving high screening rates in our academic clinic. The first cycle involved resident and faculty education of colorectal screening guidelines based on the American College of Gastroenterology recommendations. This education session also defined healthcare disparities, overviewed social determinants of health, and their effects on low screening rates in our patient population. Our second cycle created a patient conversation checklist provided at our outpatient site to address barriers to screening during any visit for a patient who had not yet completed colorectal cancer screening. This reviewed the importance of screening and adherence to screening regimens with the patient and also offered non-invasive methods of screening. Currently, our PDSA cycle is specifically aimed at identifying language barriers as a cause of healthcare disparity for colorectal cancer screening. For our QI study, patients between 45 and 75 years old who had not undergone screening were identified. Those who were lost to follow-up, refused demographic questioning of race, gender, ethnicity, or primary language were excluded. EMR documentation for each patient was thoroughly reviewed to ensure screening had not been previously completed. Patients were then contacted by phone to identify those with a self-reported language barrier. Those patients without a language barrier were educated and asked about their thoughts on colorectal cancer screening. Those who were identified to have a language barrier were sent colorectal cancer screening education by mail in their native language and instructed to bring the information in to their next visit. Pre-intervention, 107 patients were identified who lacked colorectal cancer screening. 21 of these patients were identified to have a language other than English listed in the EMR, which is 19.6% of patients. This was one of the largest minority groups we had who were missing colorectal cancer screening when compared to racial, ethnic, and gender-based disparities evaluated in previous PDSA cycles. Language distribution of these patients included Albanian, with the majority, followed by Spanish, then Urdu, and Korean. We reached out to each patient individually and were able to contact 16 of 21 patients. After establishing contact with individual patients, 56% of our patients expressed interest in colorectal cancer screening. When asked about the barriers to previously obtaining screening, the most common answers included not fully understanding the importance of testing despite previous information presented and not finding the time to complete a test due to personal obligations. 6 patients were provided with standardized educational information in their primary language and encouraged to bring the document with them to their next appointment. Of 16 patients, 6 patients were also provided with orders for colorectal cancer screening, which was either an order for Cologuard or a referral to see a gastroenterologist for colonoscopy based on their preference. 3 patients had completed the screening by the time they were seen in the clinic during the post-intervention window. Our study has a potential for a 46% improvement in screening rates for the 2024 year. However, we plan to reevaluate with a formal post-intervention data collection in June of 2024 to determine how many of these patients have completed their screening. The most important takeaway from this study is identifying barriers to care, and colorectal cancer screening is a vital yet easily missed step in providing age-appropriate cancer screening. Our PDSA cycle makes it evident that personalized conversations with patients regarding their health provide the best outcomes for preventative health care. For patients with limited English proficiency, education in their native language or the presence of an English speaking family member during these conversations is likely to increase rates of screening, as patients were more likely to understand the risks of waiting and the benefits of screening. Thank you for your time. The next session will be the Q&A.